Dear Mr. Chairman, dear colleagues, hello. It's a great honor and pleasure for me to be invited in this great Congress. I'm really happy to participate, and I would like also to congratulate the organizing committee for the excellent job they are doing. So the program is quite interesting. I would like to say that I have no conflict of interest, and apart from the fact that I've been invited from friends and great colleagues, there's nothing to declare. Here it says in Greek kalimera, which is good morning in my language, and it's only a bit of a sea which is separating our two countries, and hopefully next time I'll be able to travel and visit your beautiful country and be there on site with you. We do know that borderline ovarian tumors, we know about them since late 60s. It is a heterogeneous group of non-invasive tumors, intermediate lesions between benign and invasive carcinoma, of still of uncertain and low malignant potential and atypical proliferation. They account for about 10 to 20% of all ovarian epithelial tumors. There has been an increase in detection rates and incidence of borderline tumors within the last few decades. Perhaps it's because also we have become better with our clinical and scan ultrasound examinations. What is characteristic about epidemiology is that the average age of these patients is about 10 years less than the average age of women who suffer from ovarian cancer. That means that we mostly deal with young patients. 1/3 of them actually will be less than 40 years old. There are still controversies surrounding the optimal management. This is what we're going to try to discuss with my presentation. And our aims are two. One is to minimize the risk and operate our patients properly in a proper manner. And the second is, if it's possible, to preserve their fertility. This is the latest histological separation of various types of borderline tumors according to the WHO. The micropapillary variant has been added to the series borderline tumors. Microinvasion less than 10 millimeters. It is possibly linked to a worse prognosis. It is described in different histological types of borderline tumors. And that's the staging. Whatever it's beyond stage 1, it is considered to be advanced disease. Prognosis. As for the prognosis, the time of the diagnosis, we do know when we're dealing with cancer. Generally, it's very, very important. Thankfully, in almost 80% of cases, the diagnosis of borderline tumors will be at FIGO stage 1. As for the recurrence, this might occur anytime, even 10 years after the initial management. But the risk of an invasive form of borderline tumor is quite low. It is between 0.5 to 4%. And for FIGO 1 stage, it's only 5%. Only for extended disease, it might be up to 25%. Thus, the prognosis seems to be excellent if we treat properly our patients and we discover early the disease. For stage 1, the survival rates are close to 90%, and even for advanced disease, the 5-year survival rate will be quite as high, between 65 and 90%. So, what is the way to manage the borderline tumors? We need to take into consideration age, fertility preservation, and the stage of the disease. And a lot of dilemmas we have regarding the way we are going to operate our patients and how. Laparoscopy or laparotomy, cystectomy or subegoforectomy. Restaging, is it needed and when? What about hysterectomy? What about lymphadenectomy, omentectomy, appendicectomy? What is the role of chemotherapy? Surgical decisions and surgical practice. When we decide to do a radical staging surgery, we do know what we do. We remove practically everything in order to reduce the chances of recurrence, but this will mean a risk of overtreatment to a lot of our patients, a higher morbidity, we do know that, and of course, we are causing infertility. Conservative surgery, it is an option. We preserve the uterus and we try to preserve as much as possible of a healthy ovary. That will mean that a lot of these women will manage to achieve pregnancy afterwards, after the treatment, but we have a higher risk of recurrence, about 10% higher than the radical surgery. Laparoscopy or laparotomy. The decision is mostly based on the skills. Laparoscopy is more frequently used when we're treating conservatively our patients. There's no higher recurrence rates between laparoscopic or laparotopic approach. Laparoscopy, we do know that has a lower morbidity and fewer adhesions, which means better outcome regarding fertility. We have similar overall survival rates, but with laparoscopy, we have higher rates of rupture of the cyst. With the laparoscopy, if we decide to use it, we have to be able to perform whatever is needed to treat properly and stage properly our patients. That means to be able to examine thoroughly the peritoneal cavity, to perform the cystectomy, salpingoforectomy, to go for peritoneal washings and peritoneal biopsies, endometal biopsies or removal, and to examine or remove the appendix. As long as we are able to do this, it is a very good option. For early stages of borderline tumors, if we decide to go for a conservative management, it seems that laparoscopy is indicated mostly. In menopausal patients, when preservation of fertility is not needed, then the treatment of choice is bilateral salpingoforectomy. In treatment of unilateral or bilateral serous borderline tumors, when we have to preserve the fertility, we need to perform a cystectomy. But for mucinous, when the treatment strategy is again fertility, we should perform a unilateral salpingoforectomy. So this is the guiding map, how we should treat early stage of borderline tumors with the aim to preserve fertility for serous laparoscopic cystectomy without rupture, and definitely laparoscopic salpingoforectomy in cases of a mucinous first stage borderline tumors. We do know that the cystectomy is one of the first operations we learn to do during our apprenticeship in endoscopic surgery. So it is indicated for fertility presentation in serious cases, but it needs to perform properly without rupturing our cyst because we are going to overstage our patient. And after removal of the pathology, we should use the safety endobag in order to remove it properly from the peritoneal cavity, avoiding any spillage. As for adenexectomy, is the standard choice for a more radical treatment, especially for when we're dealing with a mucinous pathology. And the aim is to remove the whole adnexa without touching the ovary, so minimizing the risk of rupture of the cyst. The best approach is perhaps to make a window fenestration by dissecting the anterior and posterior layer of the broad ligament, so that we will be able to dissect and to separate the whole adnexa from the rest of the pelvis, especially from the ureter and the bowel. Our assistant is just lifting the round ligament, and we use our bipolar and our scissors in order to skeletonize and dissect the IP ligament without touching the rest of the adnexa. That means safety, less adhesions, less morbidity for our patients. And of course, after we safely separate the adnexa, we're going to use again the endobag in order to remove it from the peritoneal cavity. Do we need to do lymphadenectomy or hysterectomy in early stages of borderline tumors? It's not recommended, either hysterectomy or lymphadenectomy for serous or mucinous types. But for the endometrioid type, when there's no strategy to preserve fertility, we should complete our operation by performing also a hysterectomy. In cases that we need to keep the uterus for fertility reasons, we can do that, but we need to follow up very, very closely with the ultrasound and the endometrial biopsies our patients. As for advanced stages, lymphadenectomy or hysterectomy, there's no clear indication. It's not actually recommended routinely. There's no sufficient data even for routine hysterectomy. And of course, there's no contraindication for laparoscopy. In a patient with a desire to achieve pregnancy, we can follow a more conservative management by keeping the uterus and the part of the ovary. There's no need in these cases to take a biopsy from the other ovary if it appears macroscopically to be healthy. What about restaging? When should we do that? For all early stage serous borderline tumors, for micropapillary architecture, or when our first operation wasn't good enough regarding the inspection of the abdominal cavity, we should revisit our patients. And the same applies for all mucinous borderline tumors when we have performed initially a cystectomy, because in this case we need to perform an adnexectomy. As for the advanced stages of borderline tumors, we need to reoperate them in order to remove all potential lesions which have been left behind during the first procedure. What do we do with restaging? We perform peritoneal washings, ometectomy. Of course, we perform the salpingoforectomy. We visualize the appendix and remove it if needed. And we explore the whole abdominal cavity with peritoneal biopsies. As for chemotherapy or hormonotherapy, actually there's no proven benefit. Chemotherapy is not going to decrease the relapse rate. It's not going to improve the survival rates. And even for advanced stages, the decision should be made on the basis of a multidisciplinary approach. And as for the estrogen positive receptors, there's still a no response to hormonotherapy. As for completion of surgery, this is a question we need to answer to our patients after a lot of years of follow-up. Should we operate them? Well, it depends on the histological subtype, the FIGO stage, the patient's own choices, and the type of the conservative surgery we have done initially. It's not mandatory actually for stage 1. It is a very low risk of relapse, as we have said, but we should consider it when there is a high risk for invasive ovarian tumor. But most of the cases, the stories like that, the woman has completed the family planning, has achieved her pregnancy. It's been several years after the first operation. There's no clear guidelines to reoperate them for mucinous, and actually it's not recommended if it was a serious borderline ovarian tumor. For how long and how do we do our follow-up? It's good to use the transvaginal ultrasound. It is optimal to do that, and we can use also the serum tumor markers as long as they have been elevated initially. How often? For the first 2 years, quite often, 3 to 4 months, and then for the next 3 to 5 years, twice yearly, and then for the rest of the period, once yearly follow-up is quite enough for these patients. As for the infertility treatments and the choices we have, we need to follow an individualized approach. There's no evidence to justify a delay between surgery and ART. Of course, there's no evidence to contraindicate the use of ART, and there's no contraindication for ovarian stimulation if it is needed. Cryopreservation of the ovarian cortex or puncture of immature oocytes might be a solution in some difficult cases. And of course, multidisciplinary approach is always needed, especially for cases with recurrence of the disease. As for pregnancy and borderline ovarian tumors, pelvic ultrasound is the first-line examination, but we can also ask the advice of an MRI after 12 weeks. Tumor markers, we all know that they're unclear for these cases. They are elevated anyway in pregnancy. Cystectomy or adnexectomy can be performed in pregnancy in the second trimester, even laparoscopically, as long as there are specific surgical skills. As for expected management, I have no answer to that. There's still not clear evidence, and it is step-by-step individualized approach. So, reaching to the end of this session, some take-home messages: how we should optimally treat borderline ovarian tumors, how should we offer the best of benefit to our patients. Early stage borderline series of mucinous ovarian tumors. If there's no desire to preserve fertility, straightforward bilateral adnexectomy and the full package of staging with peritoneal washings, exploration, omentectomy, and removal or inspection of the appendix. If there is a desire to preserve fertility, for the serious types, we perform a cystectomy. For the mucinous, we have to perform a unilateral adnexectomy. For early stage endometrioid type of borderline tumors, still if there is no fertility issue, we add to our bilateral adenexectomy, the total hysterectomy, and the full staging steps. As for the cases who desire fertility, we can keep the uterus as long as we follow up with ultrasound and biopsies, and we perform either salpingoforectomy or a cystectomy, depending on the size and the stage of the disease. About restaging, specific indications for that, for all serous borderline tumors, if there is micropapillary serous pathology, or if we're not happy with our first peritoneal exploration. For the mucinous, we should reoperate and perform another adenexectomy if the first operation was just a cystectomy. As for the surgical management of recurrence, obviously we need to be a bit more radical, depending also of the fertility issues. It is recommended to perform a unilateral adenexectomy or bilateral if there's no fertility issue, and in cases of an endometrioid borderline ovarian tumor, a hysterectomy. So what is the best treatment of the borderline ovarian tumors? Individualized approach depending on the age of the patient, deciding the way we are going to operate them, depending on our surgical skills and the safety of our patients, and of course, the needs of our patients regarding the maintenance of fertility and their choice. So thank you very, very much for the invitation.